Welcome to Easy Anatomy. I'm going to talk to you about facial nerve, the whole story of facial nerve from the beginning up to the end. So I start from the brainstem. Facial nerve has several nuclei in the brainstem, like including in medulla, and also pons. Okay, but does not have anything in midbrain. Okay, so it has, if you remember, facial nerve is a mixed nerve. It's a mixed nerve, contains several kind of fibers. It has motor fibers supplying muscles of facial expression. It has parasympathetic fiber supplying all glands in head except parotid. When I say all glands in head, this include submandibular salivary gland, sublingual salivary gland, include nasal glands and palatine glands. Nasal glands, palatine glands, and also lacrimal glands. Lacrimal gland. Okay, so all glands in the head except parotid gland. Then it has sensory fibers, and we're gonna stop here at the sensory fibers because we have two kind of sensation. The first one, which is taste sensation, and general sensation. Taste sensation from anterior to third of tongue. General sensation part of the ear. Okay, external ear. So basically, this kinds of fibers, it means that it has like several kinds of fibers, motor to muscles of facial expression, not only facial expression muscle, it's also supply. I'm summarizing everything to start with, so hopefully this make easy to follow later on. So in addition to muscle of facial expression, it's supplying stylohypoid muscle, okay, posterior pillar of digastric, and also stapedius muscle, and this is a muscle located in the petrosal bone inside the ear. So stapedius muscle, muscles of facial expression, stylohypoid muscle, posterior pillar of digastric. Okay, parasympathetic, all glands in the head. Then sensory, you have taste sensation and general sensation. That's why when you go into the brainstem, you will see that facial nerve is related to four nuclei. Four nuclei. The first nucleus is motor nucleus. Second nucleus is parasympathetic nucleus. This parasympathetic nucleus is called superior salivatory nucleus. The inferior one related to glossopharyngeal. The third nucleus is for taste sensation is called Nucleus solitarius, located in medulla. The fourth one is spinal trigeminal nucleus. This is related to general sensation. So the one for general sensation is the spinal trigeminal. The one for taste sensation is Nucleus solitarius. So if you go here inside the brainstem, you will see that we have in the lateral side here spinal trigeminal nucleus, which is a huge nucleus located in the lateral part of medulla. Spinal trigeminal nucleus is the midline. You have right and left. Then nucleus solitarius, located also in medulla, and the upper part related to taste sensation mainly. This is nucleus solitarius. So this is the spinal trigeminal nucleus, and here is the nucleus solitarius. Then you have the motor nucleus, which is located here and located in pons. So this is medulla, that's pons, that's midbrain. So this is a motor nucleus. Okay. Then we have superior salivatory nucleus. The superior salivatory nucleus is located also in pons. Superior salivatory nucleus, and this is the parasympathetic nucleus. Okay, parasympathetic nucleus. So we have four nuclei in the brainstem. What I would like to emphasize here that with the motor fibers is coming by itself, okay. However, the sensory and parasympathetic fiber, they join each other, they form another root for the nerve. This root is called nervus intermedius. It's called what? Nervus intermedius. So you have parasympathetic, you have sensory, the two kinds of sensory fibers, all of them join each other, they form what we call it nervus intermedius. This one is called intermedius. Why it is intermedius? Because it's located between the facial nerve motor fiber and the vestibulocochlear. Vestibulocochlear, which is number 8. Okay, so this is how facial nerve is going to exit brainstem. Is going to exit brainstem as two roots, one motor, and the other one is fibers from the parasympathetic and fibers sensory, which include two kinds of sensation, the taste sensation and general sensation. So this is called the nervus intermedius, and this one is the motor root. Okay, so this is how to start facial nerve, general idea. So facial nerve, to start with, it is a mixed nerve. This is cranial nerve number 7. It is a mixed, it has muscular branches going to muscle of facial expression, going to muscle inside the ear is called stapedius muscle, and stylohypoid muscle posterior belly of digastric. Okay, in addition also we're gonna talk about muscles of the scalp, which is occipitofrontalis muscle, the occipitalis muscle, and auricular muscles. So those are all muscles supplied by facial nerve. Parasympathetic fibers, all glands in the head except parotid. Then you have sensory, two kinds of sensory fibers, taste sensation and general sensation. In addition to that, if you go deep into the brainstem, you will see that you have facial nerve is linked to four kinds of nuclei: the motor nucleus, the parasympathetic, and the spinal trigeminal nucleus, okay, for general sensation, nucleus solitarius for taste sensation. And the parasympathetic and sensory fibers join each other and they form nervus intermedius, one of the root of two roots for facial nerve when it exits brainstem. Okay, I will spend 1 minute more on facial nerve nucleus. If we need to understand, here is on the other side, we can draw it on the other side. Facial nerve nucleus if you wanted to talk about facial nerve nucleus in more depth, you will see that facial nerve nucleus divided into two parts, upper part and the lower part. This is the lower part, and the upper part. Upper part is the green one, lower part is the red one. Okay, the upper part is bilaterally controlled by brain, by cerebral cortex. It means that it receives higher control from both sides. This is the upper part. Okay, receive. I'm going to do it on one side for easy understanding. So the upper part, upper half of the nucleus, controlled by left side of the brain and the right side of the brain. So it has a spare. If one side has problem, the other side is still working, so the upper part of the nucleus is okay. And the upper part of the nucleus is responsible for the upper face, supplying the muscles of upper face. If I say muscles of the upper face, give me an example, like orbicularis oculi muscle, okay? This is one of the most important. Frontalis muscle, corrugator supercilii, nasalis. So all these muscles in the upper half of the face, levator labii superioris, etc. So upper face is controlled by two sides of the brain, right and left side of the brain. The lower part of the nucleus supplying lower half of the face, lower face. When I say lower face, like triangularis muscle, depressor labii, platysma, okay, those muscles, buccinator. So those muscles supplied mainly by the lower half of the nucleus. Okay, basically, the lower half of the nucleus is controlled only by the opposite side of the brain, opposite side of the brain. So now, if I ask you, if there is problem in the left side, if there is a problem here, which part of the face is going to be affected? The one which controlled by the two cerebral hemispheres, the two motor cortex, or the one which controlled only by the opposite side? For sure, the one which is controlled by one side. So if the left side affected, left cerebral hemisphere affected, so lower face is affected. Lower face is affected. And if your patient coming to you, and if you see that the lower half of the face is paralyzed, however the upper half of the face is okay, it means that it has upper motor neuron lesion. Upper motor neuron lesion. Okay? At that level, cerebral cortex, in the opposite side. If you see that right half of the face, right lower half of the face is affected, right lower half of the face is affected, it means that the lesion in the left cerebral hemisphere. Why the upper half is not affected? Because even if this affected, you still have this intact. It was not affected, unless it is bilaterally injured. If there is any problem, bilateral on both sides. Otherwise, only the lower face is the one which affects. And this is differentiate between the upper motor neuron and the lower motor neuron. Because lower motor neuron means that there is injury in the nucleus, there is injury in the nerve fiber or the muscle. Either nucleus or nerve fiber or muscle itself. So lower motor injury means that the whole side of the face and the same side of the injury. Whole side of the face will be affected, and it's gonna be in the same side. Like if there is any lesion here, it means the whole side of the face here is affected. And this is with the quick look at your patient, you can differentiate between upper motor if the lesion in the brain or the lesion in the nerve or muscles, okay, or in the nucleus. If the whole side of the face, if the left side of the face, for example, is affected, you see that there is no transverse wrinkling in the forehead. You see that the eye is widely open. You see that the angle of the mouth is dropped. It means that upper and lower involved. It means that it's lower motor neuron paralysis. However, if you see only the lower half of the face is affected and the upper half is good, it means that it's upper motor neuron paralysis on the opposite side of the eye. If the right lower face affected, so is left hemisphere, left cerebral hemisphere affected. I wanted to start with this beginning, like giving a general outline about the beginning of the nerve and overview of the nuclei and summary for the distribution of the nerve. Now, let us trace and follow the nerve from the beginning to the end. From the beginning to the end. Okay, now we learned that here is medulla, then you have pons, then you have midbrain. Okay, now let us start from here. This is the spinal trigeminal nucleus. This is nucleus solitarius. This is motor nucleus. Then you have superior salivatory nucleus. Superior salivatory nucleus. Okay? So, motor, superior salivatory nucleus, nucleus solitarius, spinal trigeminal nucleus. And we know now that this is for general sensation, taste sensation, parasympathetic, and for muscles. And then we talked that this is one root, and then this and that and this all together they form another root. So you have two roots. Root including the parasympathetic, the general sensory, and the taste together, and this is the nervus intermedius. Nervus intermedius. Let us make it in blue color. So the facial nerve then enter the foramen in the back of petrosal bone is called what? Internal auditory meatus. Here is the internal auditory meatus. Facial nerve enter as two roots. The root, which is this blue color, nervus intermedius, parasympathetic, and sensory. Okay. So this is internal auditory or acoustic meatus. Here is the facial nerve. Inside the petrosal bone is getting into what we call it facial canal. Inside the facial canal. And it go in not straight, but it has like a knee, like course here, and we call it genio. Then go outside the skull through another foramen. This foramen is called what? Stylomastoid foramen. Stylomastoid foramen. So the nerve came out through stylomastoid foramen. Once it come out through stylomastoid foramen, what is going to happen? It's going inside the parotid gland. Here is the parotid gland. And inside the parotid gland is penetrating the posteromedial surface of parotid gland, then start to divide into the 5 terminal branches. Temporal branch, zygomatic branch, buccal branch, marginal mandibular, then cervical branch. Those are the 5 terminal branches. Temporal, then zygomatic, then buccal, marginal mandibular, and cervical. Those are the 5 terminal branches. Before getting into the parotid gland is going to send this posterior auricular branch. The posterior auricular branch is the one which supply the occipitalis muscle. Occipitalis muscle plus the posterior auricular muscle, auricularis posterior, and maybe superior also. What are branches of facial nerve through its course? Those are the terminal branches. But before coming out from the petrous bone, so this is the petrous bone. He has its own course inside here, inside the petrous bone, is going to give 3 important branches. The first one in the top here, there is a ganglion. It's called geniculate ganglion because it's at the knee area. This ganglion is the origin of greater superficial petrosal nerve. Greater superficial petrosal nerve. And we're going to talk about the story of greater superficial petrosal nerve. Then the second one is going to muscle. It's called stapedius muscle. To stapedius, nerve to stapedius. The last one is coming few millimeter above the stylomastoid foramen and coming out through squamotympanic fissure. This is called chorda tympani nerve. Chorda tympani nerve. Chorda tympani. And each of greater superficial petrosal and the chorda tympani has long story, but the bottom line that those 2 nerves are important in carrying parasympathetic fibers plus taste sensation. Taste sensation. Okay, so this is, you need to know that the greater superficial petrosal and chorda tympani are the one who carrying parasympathetic and the taste sensation. Okay, so more detail about those nerves. The greater superficial petrosal nerve is coming through this hiatus. So if we want to follow the course of facial nerve is coming from the brainstem, which is located here, and travel laterally, go to the internal auditory meatus, traveling through facial canal inside the petrous bone. And in this area, if you see here, this hiatus and the groove for greater superficial petrosal nerve. So the greater superficial petrosal nerve coming through the anterior surface of petrous bone and traveling down here up to foramen lacerum. And from foramen lacerum, continue its trip through pterygoid canal. If you remember, we talked about pterygoid canal before. Here is the location in this area exactly. Okay, and before getting into pterygoid canal, it is joined by the deep petrosal sympathetic nerve, deep petrosal sympathetic, which is coming from the plexus of nerves around internal carotid artery. Here is the location of internal carotid artery, and here is the carotid canal. So there is sympathetic plexus around the internal carotid artery. From there, a small branch is called the deep petrosal nerve is coming here and joins the greater one. They form nerve of pterygoid canal. They form together nerve of pterygoid canal. Okay, how about chorda tympani? Chorda tympani coming, here is the ear inside here, is going to exit through the squamotympanic fissure, especially at the medial end here. We call it petrotympanic fissure. And the chorda tympani is going to join what? Is going to join lingual nerve. Is going to join lingual nerve until it reaches to submandibular and sublingual salivary glands. So those are the 2 important nerves inside. Okay. Then you have posterior auricular. Posterior auricular go and supply occipitalis muscle. Here also posterior auricular send the branch to stylohypoid muscle and posterior belly of digastric. And the posterior belly of digastric. So posterior auricular nerve is the first branch coming from facial once it exits the petrous bone through stylomastoid foramen. And it supplies more than one muscle, including stylohyoid muscle, posterior belly of digastric, auricularis posterior, and the occipitalis muscle. Those are the muscles supplied by posterior auricular. Then penetrate the posteromedial surface of parotid gland where it divides into the 5 terminal branches, and those branches supplying muscles of facial expression. Inside the petrous bone has 3 branches: greater superficial petrosal, nerve to stapedius, then chorda tympani. Keep in mind the level of injury is important, or effect of injury depend on the level of injury. So usually it starts below the damage. Like for example, if there is damage for facial nerve here, when you can conclude that the damage in the facial nerve after stylomastoid foramen, if there is paralysis of the muscles of facial expression, however, there is no effect on taste, there is no effect on parasympathetic fiber, on glands. So if the injury here, only gonna be muscular damage. However, if the injury above here between the geniculate ganglion and the chorda tympani, so chorda tympani will be lost. It means submandibular and sublingual salivary gland and the taste sensation from the anterior 2/3 of the tongue are going to be lost, because chorda tympani is the source of this function. Taste sensation the anterior 2/3 and salivary secretion from submandibular and sublingual. If the injury above greater superficial petrosal or inside the brain is a cranial cavity, it means that you lose everything. You lose all function of the facial nerve. It means that there is paralysis of facial muscles, paralysis of stylohyoid, posterior belly of digastric, occipitalis. There is loss of sensation from the anterior 2/3 of the tongue. There is loss of secretion from lacrimal gland, from nasal gland, palatine gland, and also submandibular, sublingual gland, because greater petrosal responsible for lacrimal and palatine and nasal glands. However, chorda tympani is responsible for submandibular, sublingual, and taste sensation from the tongue, anterior part of the tongue. Okay, so in summary, again, here is the facial nerve. Give this greater superficial petrosal, which is going to be joined by the deep petrosal nerve. They form together. So deep petrosal nerve, sympathetic, and this is greater superficial petrosal nerve, parasympathetic. They form a nerve of pterygoid canal or Vidian nerve. Then is going to reach to trigeminal fossa. There is a sphenopalatin ganglion. The parasympathetic fibers stop here. Postganglionic fibers come out and go to lacrimal, nasal, and the palatine. How they arrive or how they reach to this target glands, okay, to lacrimal or nasal or palatine, this will join the zygomatic branch of V2, here is the zygomatic branch, then lacrimal branch of V1. How this arrive to nasal glands? Through sphenopalatin nerve of V2, and this through greater and lesser palatine nerves of V2. So basically, maxillary nerve is the one which is going to carry postganglionic fibers to spread it. and distributed to the lacrimal, nasal, and palatine. Chorda tympani nerve. The chorda tympani nerve is coming out and going to join lingual, and from there is going to leave the lingual and to the submandibular ganglion, and from there postganglionic fibers are going to sublingual gland and submandibular gland. However, some fibers continue to the anterior part of the tongue, as we discussed in another part, in another lecture. Here is the anterior 2/3 of the tongue. Chorda tympani responsible for taste, and the lingual responsible for general sensation, pain, temperature, and touch. So this is the lingual. Okay, so we discussed this in other section. So keep in mind that greater petrosal is going to be distributed through V2 and V1 to those glands, and this chorda tympani nerve is going to be distributed to submandibular sublingual through lingual nerve, which is branch of V3, and some fiber extend to the tongue for taste sensation. So this is facial. Okay. So facial nerve paralysis is very important. We talked about how to differentiate between the upper and the lower motor neuron. This is very important section. And the most common form of the lower motor neuron paralysis is called Bell's palsy. And Bell's palsy, it is idiopathic and non-reason. However, you need to keep in mind that it can be complication of systemic disease like diabetes, viral infection, uremia, okay, and others. Okay, it can be traumatic injury, result from traumatic injury of facial nerve in the face, and especially in parotid gland. So lower motor neuron paralysis, which is characterized by paralysis of whole side of the face, upper and lower, upper muscles and lower muscles. So ipsilateral, same side of the injury, the whole face. And keep in mind that it's idiopathic, but it can be complication of diseases like diabetes or uremia or cancer or viral infection. Okay, it can be traumatic, especially if there is injection for to block some nerves when you work on teeth, and the needle can penetrate the posteromedial surface of parotid gland, leading to facial nerve paralysis. Okay. If it is lower part of the face only affected, it means that this is upper motor neuron paralysis. It's gonna be contralateral paralysis of lower face, lower half of the face. Okay. And the major complication, imagine that the eye is widely open. It means that the cornea is going to be dehydrated, and corneal ulcer can be complication from facial nerve paralysis. That's why one of the important things to take care in your patient is to cover the eye and refer him to ophthalmologist. Okay, otherwise the cornea will be damaged. Thank you.